We're going to cover a balance of a couple cases you've already seen, you'll take it as unknowns, and a couple pretty atypical cases that you may not have ever seen. All right, I do have disclosures as listed above. We're going to start with a 30-year-old woman with renal pseudoaneurysms. All right, image of the right kidney. Anything wrong with this kidney? So diffusely echogenic. That's right kidney. That's left kidney. Diffusely echogenic. Shadowing behind. Anybody want to go ahead and throw out the diagnosis? Huh? Angiomyolipoma, good. Echogenic, fatty, right? What about now? Liver lesion. And then 2 video clips. This is showing you that IVC with similar echogenic tracking all the way up into the IVC. And then your last video. This is through the liver. So innumerable small echogenic foci throughout the liver. Tuberous sclerosis, good. But what else beyond tuberous sclerosis? So these are angiomyolipomas, gigantic angiomyolipomas. You can see the pseudoaneurysm, which is bled in this one, and it's known for having multiple angiomyolipomas. I'm going to draw your attention to this fatty thrombus going up into the IVC, and then it's showering these small little fatty lesions throughout the liver. So this is an invasive angiomyolipoma. So little pieces of the material showering into the liver, combination of ultrasound and CT criteria. Very rare. We've only had a couple of cases of this at UAB, but maybe 3 or 4 since I've been there. This was the patient with that bleed is what brought them here. And so this was the selective artery angiogram showing the multiple round pseudoaneurysms. This is why they bleed. So it's not the angiomyolipoma itself, it's the small dysmorphic vessels within it that lead to the hemorrhage. Combination of smooth muscle, adipose, and blood vessels. And then again, risk of hemorrhage in these patients. All right, that's probably going to be the weirdest one that we'll see today. So 50-year-old male with a renal transplant dysfunction. And by the way, I'm not going to go slow just to keep us here the whole time. So if we get done and you're participating well and give me the answers, we're going to move on through. All right. This is transplant kidney. So if you've been in here, you should know the answer. What is the answer? So yes, the answer is renal vein thrombosis in this case, but I'd rather you had said reversal of diastolic flow, because we've got a little bit of a difference here. This is the second version, second picture from it. We've got a continuous waveform of reversal of diastolic flow. So this is not just a little blip. This is continuous. So this goes along with the original works of Buter and Caveglia. Buter, when they first saw this, very first time they ever saw this, they said, this is renal vein thrombosis. That's what this is. It's always going to be that. Well, Caveglia came along and said, well, not so fast, not so fast. It can be renal vein thrombosis, but it could be a number of other things that can also cause that very high resistance. I will go ahead and tell you, in this case, it is renal vein thrombosis. And here is the CT that was done with contrast, even though I would not have preferred to have it happen that way. And you can see this round filling defect right here, consistent with the renal vein thrombosis. So renal vein thrombosis, visible clot is actually the best sign. If you can see the clot in the vein, and transplant kidneys are actually very superficial, so you often can actually see the vein really well. But reversal of diastolic flow is very common, and it should be throughout diastole, not just a little blip. Transient really is not predictive at all. So here's the difference. We looked at 5,089 renal transplant ultrasounds over a 10-year period. So we're doing about 500 a year. And we looked at every single case, no predisposed, no bias, not looking up a lit search, not looking up reports, every single case. And we identified only 59 out of 5,000 patients. Well, here's the problem. All comers, 30 of them on the final EMR, path, biopsy, surgery, clinical follow-up, the final diagnosis was severe rejection. 25% was due to ATN, and only 10% was due to renal vein thrombosis. Now, you say, well, what about maybe it's because you're, anywhere from 1 to a year. What if it's only in the first few days? You are going to have a higher chance of it being a renal vein thrombosis in that first 24 to 48 hours. And in that case, 1 of the 6 cases, 16%, actually was a renal vein thrombosis. So even then, though, it was less than ATN. If you take less than 30 days, it goes down to around that 10% rate because, again, even by 30 days, rejection was overwhelming renal vein thrombosis as the etiology. So even though when you're taking a test or evaluating this, and you're saying, what's the most common type? Yeah, it's rejection. That's going to be. But I want you to keep in mind, in that first early phase, you still need to be very cognizant of renal vein thrombosis, and you still have to chase it. Here's the other problem is if it's rejection, they do terribly. Most of these kidneys will go on to failure because most of these are not caught in that first 24 hours when if you're monitoring them every hour and seeing every little thing and you catch it instantly, they've got a chance. But after a couple days, they're not checking every few minutes, every hour. And if it sits there for a little while, the kidneys just do not do well. Renal vein thrombosis, 80%, and the only one that survived was within 24 hours. Acute rejection was 27%. Hematoma and kink. The good news about ATN and hematoma or kink is they do great. And especially in that first 24 hours, half of the cases were due to hematoma. They go in, they take out the hematoma, just like Dr. Grant said, and it does beautifully. But if it is rejection or RVT, not so good. Again, 5,000 cases, prospective. Next patient is a 40-year-old male with scrotal pain. Right side. Left side. Any ideas, thoughts, anything catch your eye? That's a little subtle until I give you your last picture, but, Focal zone is right in there, and that's why you've got more flow superficial. What do you think of the scrotal wall? Skin. A little thick, right? Perhaps maybe the focal zone is causing the flow in the anterior testis to be more hyperemic. But then we get this right next door to it. Now what are we thinking? Yeah, these are bubbles of gas. This is Fournier's gangrene. Multiple bubbles of gas in the subcutaneous tissues. Scrotal wall thickening, maybe some inflammation of the adjacent testis. But remember, the testis actually has a different blood supply. So it would be an innocent bystander effect due to the surrounding inflammation. Occurs in diabetic elderly men. This person was a little younger than you'd typically see it in. This does require surgical debridement. Ultrasound findings are scrotal wall thickening, subcutaneous gas. Ed Grant talked about that dirty, or he used another word for it other than dirty shadowing, but the shadowing that's not a pure, clean shadow, and then looking for hyperemia on the Doppler. Just as another example, this patient did not have Fournier's. This one was a case where these shadows were a little darker, and this was calcifications in the subcutaneous fat. What's the diagnosis? Dermatomyositis. So again, clinical, you're not going to mistake these two patients. They're going to have a clearly different symptom set, and this was down in the knee area as opposed to the perineum. All right, new case. This is a patient with a picture of the right epididymis and testis. What do we have here? Large, tortuous, spiral intratesticular varix. Very good. I like it. The left side was normal. Now what? Look up at the kidney. Here's your mass right here. So when you have an isolated right-sided varicocele, especially in someone over age 40, you need to look up top to either see is there adenopathy or some type of mass that's blocking the flow. There's actually, more recently, they even talk about a new onset of a left side varicocele. Then you also should look for adenopathy or retroperitoneal process. It's more common on the left. Dilated veins are somewhere between 2 and 3 millimeters. That's still up for debate, even among experts. Increased dilatation does occur during Valsalva, and it also can occur if you stand them up. Our sonographers really don't enjoy that part of the exam, so they're always hoping that they Valsalva real well so we can go ahead and see it while they're laying down. And then there's actually, I've not confirmed this myself, but there's one study that shows if you have a retroaortic left renal vein, there's probably partial compression of it because their rate of varicocele on the left was 3 times the normal population, which actually sort of makes sense. Okay. What's the diagnosis? This one's tricky. Yell it out. All right, how about now? Oh, sorry. Yeah, how about now? A few seconds later. Yeah, so had the gain turned the wrong, not quite optimized, and now that we've got a better showing of it, now we've got focal thrombus filling the great saphenous vein, not greater saphenous vein, great saphenous vein since, what, 2002, somewhere like that? Yeah, so this is great saphenous vein actually going into the common femoral vein. And then this was just with some sepia color to show it even a little bit prettier. So what you need to understand about this thrombus that I just showed you is it's a superficial clot, but even if it's not actually going into the common femoral vein, it has to be treated as a DVT study. Anytime it's within 4 centimeters, and then there's actually the TASC study that suggested even if it's a little bit longer, a little bit further away, but a long thrombus, then it would benefit from being anticoagulated. So if you see a great saphenous vein thrombus within 4 centimeters of the insertion, it's still going to be treated, so you still ought to let your doctors know that it is classified more as a DVT. All right, new patient. Right external carotid artery, longitudinal view. Okay, internalized flow. All right, internalized flow. I think I heard someone going to an answer, but what's interesting about the waveform other than it's collateralized? It's low resistance, Tarvis Harris, and it's flowing in reverse. It's above baseline going down toward the feet. So reversed collateralized flow of the ECA. So you say, well, how did that happen? Here's the ICA. So the ICA is going antegrade toward the brain. So now we've got reversed ECA, antegrade ICA, and then here's your CCA. No flow in the CCA. And then if you didn't believe it, obviously, more sensitive with power Doppler, so we put on the power Doppler. And again, we show no flow within this common carotid artery. So how does the flow get there? It finds its way from the other side to it, and usually it's either going to be the ophthalmic branches or thyroidal branches, causing collateral flow from the contralateral side. All right? Any questions on that? We good? All right. You've had a suggestion of how to get to the answer of this one, but we'll see if you get there. So main renal artery, this is in the hilum. What's wrong with the waveform? Yeah, actually, I appreciate it. Everybody's actually chiming in and answering. Thank you, because I've had talks like this before, and it's just silence, and I would have to pay somebody, like over there to yell out something. So high resistance, very high. This is 0 diastolic flow, so this is a resistive index of 1. That's in the main. This is the upper pole. Kidney swollen, so it looks like rejection, right? And then, again, no diastolic flow. Mid portion, same thing. Lower pole, normal. Resistive index is 0.66. So why do we have high resistance throughout the kidney, but the lower pole is actually normal? Pushing too hard is a good thought. Not in this case, though, but 2 arteries. So an accessory artery. So say you had a lower pole artery with a stenosis, so that you had high resistance everywhere else, but the low poststenotic flow was allowing it to come down to normal. Is there another way that you could bypass all that resistance of the rejection? maybe after some procedure that I may have, AV fistula, right. So I asked the sonographer, Karen, to go back in. She gave me the vein, and here we have a low resistance arterialized waveform in this lower pole branch. So we had diffuse rejection, but the fistula allowed it to come back down into the normal range, which is sort of what Dr. Grant showed you in a similar fashion with his case. Occurs in 10 to 15%, frequently in the lower pole because that's where we biopsy. And then if it's bad enough, it can actually cause allograft dysfunction. Like he was talking about, it can steal blood from the rest of the kidney. You want to look for that arterialized venous flow and also that tissue reverberation that he showed you. All right, 38-year-old female with carotid bruits and hypertension. Here's another one that you should get. Say it again. Arteritis, smooth, diffuse wall thickening. I can go with that. Pretty normal flow there, right? Pretty normal waveform. Still pretty normal waveform. So even though we've got this wall thickening, our waveforms are pretty good. But look at this wall. I mean, that is absolutely impressive. And notice it's a little bit echogenic. So what type of arteritis? Takayasu arteritis. So yes, this is Takayasu's. It's a granulomatous vasculitis, younger age group, strong female predilection, about 9-to-1 ratio. Look for the smooth. It can be actually a little hypoechoic, but more typical in the literature is that macaroni sign with the echogenic linear appearance. Often long segment, not very regular. It's a nice, smooth, long segment. And then the velocities, if you're not too tight, your velocities will actually have normal waveforms on the color and spectral Doppler. All right, 20-year-old male with progressive weight loss and severe pain after eating. This is just showing you the aorta so that it's not some inflow cardiac problem. The aorta looks nice and normal. This is celiac artery and SMA, celiac, SMA. Because, why are you saying that and not a stenosis? 20 years old, right, okay, they're 20 years old, so who's going to get, I guess they could have had a dissection, but you know, who's going to really get arterial atherosclerotic disease that bad in 20 years old? Also, it's got a little bit of that angulation that we worry about, the shepherd's crook type of picture, and again, this I think shows it a little better with the poststenotic dilatation and no shadowing plaques in that region. So yes, median arcuate stenosis, median arcuate ligament is a good thought on this. This is just showing the flow beyond the narrowing where you've got a high velocity, low resistance waveform going into that redundant dilated segment. Younger patients, usually thin females, and especially people who have lost a lot of weight, so that angle of the SMA and the celiac artery can change, worsen symptoms with exertion. You're going to get a J-shape appearance because the top edge of the celiac artery is being touched by your median arcuate ligament. So if the artery is like this, if you breathe in real deep, the lung comes down and straightens out the artery. If you blow your breath all the way out, the lung rises and that artery angulation is accentuated. So that's why we do the inspiration-expiration to look for the 2-to-1 ratio, because if the velocity stays the same, then you're thinking fibrotic stricture, right? But if that changes, now it's a functional positional effect. It's formed where the diaphragmatic crura fuse at T12 to L1. It's usually a centimeter above the celiac artery, so causes no problem. And then it may compress in a subset of patients. So many of you are ultrasound specialists, but I still wanted to show you the CT so you can see this median arcuate ligament coming across here. And then as we come down, you'll see it touching this anterior surface of the celiac artery with the focal narrowing. And if you don't believe me on that, we'll show you the coronal. Here's the right crus, here's the left crus, and it's touching right on top of it. And if you still don't believe me, here's that shepherd's crook angulation and touching at the level where it's coming out. Another thing is if you fix this, a lot of times the velocities get better. Now, not everybody gets better clinically, so that's why there's controversy on it. But the actual mechanical velocities, you can fix this. So 3 different studies all looked at the velocities before a repair and after, and you can see in every case, the average velocity was above the threshold that you were told for celiac artery stenosis, right? 200 above. And every time after the repair, it was back down to a normal value. In a series of 18 patients who had a surgical repair, 73% had complete resolution of symptoms after the repair, and this with a mean follow-up for at least 3 years. Controversial because you can see some of that effect even on a normal patient. Now, if you see, you're not going to see post-stenotic dilatation, but you may see a little angulation there even in a normal patient. Plus, it's not involving the SMA, so if you're considering single vessel disease is unlikely to cause symptoms, you're not sure why would it therefore cause symptoms if only one vessel is being involved. And also the success rate varies. One meta-analysis literature review, though, showed from the studies 82% success. So there is something there. All right, hematuria, this is, I think, one of my last cases. Nutcracker syndrome, yes. So here is the artery immediately past where it crosses, here's the left renal vein where it crosses behind the SMA and the aorta, right as it's about to come into the IVC. And then here it is a little more to the left. So this is coming from the kidney before it gets to the SMA, and you have this dilated vein coming to a very tapered vein. Then we can look at the velocities, and again, if you look at that inflow vessel here, only 12.6 centimeters per second, and then we have like 8 to 10 to 1 ratio once we get to the area where it's coming behind the SMA. So this elevated velocity and the difference in the size goes along with Nutcracker syndrome, as you said. Here's the slow flow coming into the level of aliasing at the transition point. Here's the CT for those who don't love ultrasound, which I hope you've already gone out to enjoy the day. It can be an etiology for hematuria. You should not really call it if there's no renal vein dilatation or no beaked appearance. And then it can really solidify the diagnosis on CT if there is a delay of enhancement of the left kidney compared to the right. But that beak-like appearance. Ultrasound criteria would be the dilated compared to the collapsed of a 4 to 5:1 ratio, peak velocity ratio of the two of greater than 4 to 5. And if you use both of those with a cutoff of 5, sensitivity of 90% and 100% specificity, and the 3 studies are listed here. Some people look at the angle of the SMA takeoff because what's going to happen is as you lose weight and that SMA angle drops, there's not as much space for the renal vein to go through. So if you're less than 45 degrees upright, or if you're supine less than 23 degrees, these are criteria that can help you diagnose it. So in summary, not every case is black and white. If you keep your eyes open, you're going to eventually find a colorful gemstone. And so turn that Doppler on, use that spectral. You're going to find more vascular structures, especially if you're looking for them. Thank you for your attention.